Welcome to Auxanö Medical, where you grow in your medical knowledge. I'm your host, Dr. Julius Kwedhi. Today we journey through one of congenital heart surgery's most demanding landscapes, hypoplastic left heart syndrome. We're going to build the narrative from its embryologic roots all the way to the nuanced physiology of the Fontan circulation. But not as a checklist. It's more of a conversation that helps your mind rehearse the flow of decisions you'll face on the ward, in the cath lab, and in the operating room.
Right.
Think of this as both a deep study session for boards or accreditation and a practical briefing for real-time clinical judgment. With me, as always, is the brilliant Anastasia, Nastya. Hi, Nastya.
Hi, everyone. I am so glad we're doing this one as a true dialogue because hypoplastic left heart syndrome, it punishes fragmented thinking.
It really does.
You can't separate anatomy from physiology or imaging from intervention. You have to let each piece inform the next, almost like a careful handover note that refuses to miss a single detail.
Exactly.
So let's start with a living case to keep our feet on the ground. A premature infant, 33 to 34 weeks, weighing just 1.4 kilograms at birth, who began life on the hybrid pathway, will keep returning to this child at each turning point.
So, hypoplastic left heart syndrome isn't a single lesion, but a spectrum.
Yes.
The left ventricle, the mitral valve, the aortic valve, and the ascending aorta are all so underdeveloped they just can't carry systemic flow. In the first days of life, survival literally depends on two safety valves from fetal life that have to continue to function after birth.
Okay.
One is the arterial duct, which we keep open with prostaglandin to let blood pass from the pulmonary artery into the aorta and supply the body. The other is the atrial level communication, a PFO or an ASD, which lets oxygenated pulmonary venous blood escape the left atrium and mix in the right atrium.
And if either of those fails...
If either fails, the house falls.
And that is exactly why the newborn with HLHS looks fine until the duct starts to close. And then they just spiral. Cyanosis, tachypnea, poor pulses, acidosis, anuria. It's not a slow decline.
No, not at all.
It's a cliff. The earliest lesson is you have to think in terms of flows and mixing, not just, structures on a diagram. The right heart, a chamber designed by nature to pump to low-resistance lungs, suddenly has to pump for both the body and the lungs. That right ventricle becomes the systemic ventricle.
Right.
Every single choice we make has to respect that hard reality.
Historically, the revolution really came with the Norwood operation in the 80s, creating a neo-aorta from the pulmonary root and reconstructing the arch so the body had a robust outflow.
A huge step.
Yeah, and later, the RV to PA conduit stabilized early diastolic perfusion in many programs. Then the hybrid approach emerged in the 2000s. So instead of performing bypass and arch reconstruction in a fragile, low birth weight neonate, you place bands on both branch pulmonary arteries and stent the duct to secure systemic flow.
Right.
That hybrid move it bought time. Time for the child to grow and the organs to recover. And our premature infant is exactly the child for whom the hybrid was devised.
So let's pull back to embryology for a minute because it really gives us compassion for the anatomy we inherit. Between weeks 4 and 8 of gestation, flow, sculpt, form.
It's fascinating.
If you reduce flow through the left heart in that window, you stunt the very structures that would normally draw blood forward. The mitral valve narrows or doesn't even form, the LV stays small and stiff, and the aortic valve and ascending aorta become thread-like.
Wow.
The phenotypes we meet are often paired, mitral atresia with aortic atresia, or they're stenotic cousins. And the right heart looks big, not because it's abnormal, but because it's doing all the work.
And that helps us keep our first two imperatives in view. One, keep the arterial duct open for systemic output, 2, keep the atrial septum unrestrictive so pulmonary venous blood can escape the left atrium and mix in the right atrium.
Absolutely.
Because if that atrial septum is tight, pulmonary venous pressure just soars. The lungs flood from the venous side and the child desaturates no matter what we do with the ventilator.
A crisis.
And that's when a balloon atrial septostomy, the classic Rashkind procedure, or stenting the atrial septum becomes life-saving. In our case, when the atrial septum became restrictive after the hybrid, the team did exactly that, a timely Rashkind.
At the bedside, I think in cares.
Okay.
The 10-minute 100% oxygen test paired with arterial blood gases, that tells us if we're fighting a cyanotic heart disease with a right-to-left shunt. A poor rise in arterial oxygen on 100% O2 is the neonatologist's red flare. We have to look at the heart now.
Right, immediately.
Then echo is the immediate anatomic truth teller. It answers all those questions. Is the LV truly hypoplastic? Are the valves atretic or stenotic? How small is the ascending aorta? Is there arch hypoplasia? How big is the atrial communication? How's the RV function?
Yeah.
Those answers are not academic. They shape the very first hour of treatment.
And in that hour, you start prostaglandin E1. When the infant is in ductal-dependent collapse, you begin at the rescue dose, 0.1 mics per kilo per minute. Then you titrate down as they stabilize.
A critical dose.
That dose is worth saying out loud because your hands should know it before your head does. Also, be really cautious with oxygen. High inspired oxygen will lower pulmonary vascular resistance, and it siphons all this flow into the lungs, which worsens systemic perfusion. The right ventricle just can't serve two masters when the lungs suddenly call the tune.
And if the RV systolic function is depressed, you'll reach for inotropes like dopamine or dobutamine, maybe milrinone if the MAP can tolerate it.
Right.
And you have to avoid those reflexive large fluid boluses. They just bloat the systemic RV and make venous congestion worse.
Okay, so now to the choice that defines the road, hybrid or Norwood. In a robust term neonate with favorable conditions, a lot of centers will do a Norwood in the first week to 10 days, build the neo-aorta, reconstruct the arch, and source pulmonary blood flow with a BT shunt or an RV to PA conduit. And that RV to PA conduit is often preferred because it supports higher diastolic neo-aortic pressure and therefore better coronary blood flow.
But in the very premature, the very small, the anatomically complex, or the metabolically fragile, the hybrid move is just kinder.
Much kinder.
You get bilateral PA bands to protect the lungs from overcirculation. A stent in the duct guarantees systemic flow. If the atrial septum is tight, you relieve it.
Yeah.
No cardiopulmonary bypass, no cross clamp. It's just time. Time for the brain, kidneys, liver, and lungs to catch up.
There is one bright red line you must not cross in aortic atresia.
Okay.
If there is obstruction to retrograde flow from the duct into the aortic arch and the coronaries, then relying on a ductal stent to feed the coronaries is
Dangerous.
very. Those babies need an arch reconstruction, a Norwood-type solution, to guarantee coronary perfusion, because coronary hunger will masquerade as low output, and you do not want to learn that lesson at the bedside.
Right.
In our program's mental model, that red line prevents us from asking the wrong physiology to do the impossible.
So let's make the hybrid concrete.
Yes.
Imagine the ductal stent as a deliberate bridge from the pulmonary circuit to the body, a protected highway for systemic flow. The bands on the pulmonary arteries are like speed governors, keeping the lungs from pulling too much blood away from the body.
Okay.
You're not trying to normalize oxygen sats. You're trying to balance the pulmonary and systemic flow in a way the RV can actually sustain. And with that balance, a peripheral sat in the 70s is not failure.
That's the key.
It's a safe set point.
And you have to watch the structure just as much as the numbers.
Right.
You surveil the ductal stent for restenosis and redilate it if needed in the cath lab. You check the gradients across the PA bands. Tight bands will record high gradients, 80 to 85 millimeters of mercury by design.
Right, as intended.
And you ensure the interatrial communication remains generous. In our infant, when that became restrictive, a balloon septostomy restored the escape valve.
So it's dynamic.
Hybrid is not a one and done, it's a stage crafted for ongoing tuning.
So when the calendar and the physiology finally meet, usually around 4 to 6 months, we consider the second stage.
Okay.
After a hybrid start, that second operation is often called a comprehensive stage 2. It's comprehensive because it reconstructs the aortic arch while also creating a bidirectional cavopulmonary anastomosis, the Glen.
The Glen.
The superior vena cava is connected directly to the right pulmonary artery, so blood from the upper body flows passively into the lungs without going through the ventricle.
And readiness for that is not a guess.
No.
We measure it. The pulmonary arteries have to be large enough, the PVR low enough to support that passive flow. The Nakata index should be over 200, the Magoon index over 1.5.
These are crucial.
The mean PA pressure should be less than 20, the PVR index less than 5 Wood units.
Right.
In our 6-month-old, the Nakata was 266.4, the Magoon 1.62, and mean distal PA pressures were 8 to 10. A beautiful green light.
Post-Glen, we set expectations. SATs between 75 and 90% is totally appropriate for Glen physiology.
Yeah.
We also set the tone in the ICU. If feasible, extubate within 24 hours. That negative intrathoracic pressure favors passive pulmonary flow and shortens the whole cascade of complications. And we are humble with fluids. For the first 3 months after a Glen or Fontan, we give maybe 60 to 80% of daily fluid needs to minimize effusions. In this physiology, too much kindness with fluids is not kindness.
Then the third stage, the Fontan. Elegant and exacting.
Yes.
The Fontan completes the separation of the body and lung circulations. The IVC blood is routed via an extracardiac conduit directly into the pulmonary arteries, often with a small opening, a fenestration, to the atrium that can decompress the system if pressures are high.
A little safety valve.
The idea is elegant. The ventricle serves only the body. The lungs are perfused passively by venous pressure.
But that elegance is conditional.
Always.
The PVR must be low, the PA's generous, AV valve regurg minimal, and the systemic RV has to be competent. If all those conditions are met, resting SATs can live comfortably in the high 90s after Fontan.
Okay.
If there's a fenestration, the SATs can be lower, but the trade-off can be a safer hemodynamic state. Fontan's success is all about physiology, not bravado.
Across all these stages, the cath lab and the pharmacy are just their companions to the operating room.
Absolutely.
For the atrial septum, a Rashkind saves the newborn with pulmonary venous hypertension. A stent can maintain that patency if restriction recurs. For the ductal stent, we tailor it, we watch it, and we balloon it if we need to.
Right.
For the branch PAs, especially after bands, we use angioplasty or stents. For arch problems, cath can bridge, but the definitive solution usually comes in that comprehensive stage 2 surgery.
And on the medical side, I always remind myself that oxygen is a medication with side effects.
It is.
In the early stages, too much oxygen lowers PVR and steals flow from the body. We aim for SATs in the mid-70s to mid-80s before the Glen. We do not chase normal numbers. That would actually harm the circulation.
Right. It's so counterintuitive.
Diuretics for congestion, inotropes to support the RV, antiplatelet therapy, usually aspirin, is standard after shunts and stents.
And nutrition.
And nutrition is a therapy. Many of these infants need NG or G-tube feeding to get the growth that makes stages 2 and 3 safer.
And the complications, they respect the stage.
They do.
After stage 1, the big threats are low cardiac output, shunt or stent thrombosis, arch obstruction, arrhythmias, infection. After the Glen, it's effusions, chylothorax, SVC hypertension, and maybe AVMs.
And after the Fontan?
After the Fontan, Early effusions and thrombosis give way over time to protein-losing enteropathy, plastic bronchitis, liver disease, rhythm disorders, and eventual decline in ventricular performance.
2 reflexes save lives. First, a sudden drop in SATs with a silent hemithorax after surgery. You have to think pneumothorax first. Ventilating an absent lung is audible, but useless.
Yeah.
Decompress if you suspect tension. Confirm and drain. Second, low output after a Norwood should light up the thought of neo-aortic or arch obstruction.
Critical.
When diastolic pressure collapses, coronary perfusion collapses. You look with echo, you go to cath lab if needed, and you fix it, sometimes with a stent, sometimes back to the OR.
Right.
The right ventricle cannot feed the body if the coronaries are starving.
And that broader mindset to troubleshoot physiology in a sequence is what keeps panic from replacing thought.
Yes.
Ventilator and chest first, then shunt or conduit patency, then arch and coronary perfusion.
A clear algorithm.
You parallel that with a measured use of vasoactives to protect diastolic pressure, and you're practicing safe speed instead of aimless haste.
We sometimes think surgery is the main act, but really, interstage care is the performance that determines if the next act can even begin.
So true.
A monthly cadence of specialized follow-up during these interstage periods and monthly for the first year after Fontan, it measurably reduces mortality. It's not bureaucracy.
No.
It is vigilance.
And each visit is a disciplined bundle. Exam, SATs, hemoglobin, an echo focused on the RV, the valves, the PAs, the arch, selected blood gases, if you're concerned, and a review of anticoagulation.
And the family's role?
Oh, it's huge.
We equip families with pulse oximeters and scales, and we teach them to notice changes in color, feeding, breathing. Parents become clinicians at home.
Wow.
And that partnership saves lives.
So let's come back to the infant who began this story.
Yes.
After the hybrid, at 6 months, the child was evaluated for advancement. The pulmonary arteries measured favorably, a Nakata of 266.4, and a Magoon 1.62, and mean distal PA pressures were 8 to 10. A beautiful green light.
Post-Glenn, we set expectations. Peripheral capillary oxygen saturation between 75 and 90% is totally appropriate for the Glenn physiology. We aim to extubate in the first 24 hours, if feasible.
If possible.
And we hold fluids to about 60 to 80% of daily needs for a few months to keep effusions from stealing the show. None of that is ritual.
No.
It is physiology translated into routine.
So if there is a single take-home for those preparing for boards or accreditation, it's this: memorize your numbers, but understand their music.
I like that.
A Nakata over 200, a Magoon over 1.5, a mean pulmonary artery pressure under 20, a pulmonary vascular resistance index under 5. These are not talismans.
No.
They are thresholds that keep passive pulmonary flow possible and let the right ventricle breathe.
And keep your first principles ready at 3 in the morning. Preserve the arterial duct with prostaglandin E1 at 0.1 micrograms per kilogram per minute in collapse. Relieve a restrictive atrial septum without delay. Avoid overoxygenation that steals flow to the lungs. Support the systemic right ventricle with inotropy rather than volume overload. Never ignore the possibility of arch obstruction when the ventricle looks ischemic after a Norwood.
Critical.
And respect that a peripheral capillary oxygen saturation in the 70s can be a sign of balance, not failure, before the Glenn.
So this has been a journey from hybrid beginnings to Fontan futures. Not a list, but a line of thought that you can walk back and forth until it's your own. You've been listening to Auxanö Medical, where you grow in your medical knowledge. I am Dr. Julius Kwedhi.
And I'm Anastasia. Share this episode with a colleague who's learning the art of single ventricle care. We'll see you next time.